Hello and a warm welcome to everyone to Oral Diagnosis and Radiology Weekend Webinar Series. Thank you for joining us for today's webinar. My name is Dr. Neerja and I'm from Faculty of Dentistry, AIMS University, Malaysia. I will be the moderator for today's session along with Dr. Ravi, who will be my co-host. Before we start, I would request the audience to bear with us at times because we may expect minor technical hitches due to speakers logging in from different time zones. I take this opportunity to express my sincere thanks to the management of AIMS University, Malaysia, and happy to partner with Amropin India for giving us invaluable support and guidance to conduct this webinar series. Coming to today's topic, it is on orofacial pain, which is the 12th specialty in dentistry, brought to us by Professor Dr.Syed Vaseemuddin. He's from India. Dr. Syed Vaseemuddin has a career spanning 14 years. He is a postgraduate teacher, PhD guide, and head of the department. He has completed a diploma in medical genetics concurrently from GWAS and was the first to do a thesis on DNA extraction from dental pulp and gender determination by PCR. He started his career in KLE Society's Dental College and has held a position of professor and head of the department in Dasmesh Dental College, Punjab. He is credited with more than 60 international publications, contributory author with Dr. Carol Stewart in an acclaimed textbook. He has the honor of being the organizing chairman of First National Undergraduate Oral Medicine Conference in Punjab and other conferences. He is on the board of directors at International Academy of General Dentists, Texas, USA, physician affiliate member of AAOP and IASP. He has also served on the editorial board of various journals. He also holds a certificate in creative and freelance writing from the University of Cardiff, UK. He has been an essential member in the inception and initiatives of Amropin and is also a passionate fitness and fashion enthusiast, a blogger, and an avid reader. We welcome you, Professor Vaseem. It's a pleasure having you with us.
Thank
Before
you.
we get started, just a little housekeeping. Professor Vaseem's presentation will be followed with a panel discussion by 3 panel experts who will share their knowledge and expertise on the current topic. Our expert panelists for the day include Professor Dr.Tatu Joy, Dr.SAJJAD and Dr.YESODA A. We welcome you all. If you have any questions during the presentation, please type them in the Facebook comment box. We'll bring them up during the presentation and we'll also have time for question in the end. Now, without further ado, we will turn the time over to today's presenter, Professor Dr. Syed Vaseemuddin, to share his knowledge and expertise on the subject matter. Prof?
Yeah, thank you, doctor.
Yes, Prof, you may proceed.
Yeah. How do I share the screen now? Yeah.
Yes, Prof. There's a screen share option.
Got it.
Yes.
Yeah. Well, can the screen be seen?
Yes, doctor, the screen is visible. Kindly choose the slideshow mode. Yes. Good, doctor.
Yes. Yeah. Uh, a very good morning to everyone. Allow me to introduce myself. I am Dr. Vaseem and I'll be pain, the 12th branch of dentistry. Uh, at first, I would like to extend my gratitude to my teacher and mentors, Dr. Rajan and Dr. Padmati. What would we be without our teachers, isn't it? Now, I today stand before you also as a representative of AmroPen. AmroPen is an initiative with the sole purpose of expanding the horizons of oral medicine and radiology. We have taken incipient seminal steps. We continue to grow, and with ventures like this, probably see a better tomorrow for oral medicine. Well, I know acknowledgements come at the end when you are done with your talk, but I would like to extend my heartiest thanks to Dr. Ruchika, Dr. Mogit, Dr. Ambika, Dr. Shika Khare, and Dr. Nishit, friends, fellow Amropians, and a support system. Thank you. Read about the definition of pain. We all have experienced pain. It's something which is called as the great leveler. It affects everyone without discrimination, without it is well, we know the textbook definition of orofacial pain being associated with sensory changes and all that. But let me get a little about pain. Well, pain reveals the dimension of life, the dimension of everything except, in fact, pain itself. This is this is a quote from Glenn Duncan. As doctors, our duty is to, you know, the patient who seek us for the treatment, and elevation of the pain is our job, prima facie. And so pain is a phenomenon which is well understood and again poorly understood. At the very outset, I want to emphasize on one point, that the base quality of a doctor is empathy. Do not be dismissive of the patient's complaint. Sometimes the patient may appear to you as being very theatrical, very repose, very clandestine, or very exaggerated. But pain is subjective. If the patient says he's got pain, he has got pain. There are scales, but I don't think there's any scale which can measure the emotion associated with pain. All right? So pain is subjective. Do not dismiss the patient's complaint. Now, pain is also a protective impulse. We are all hardwired, and it's a social alarm of a threat. But in sometimes what happens when the pain is so severe, it competes with other demands and triggers behavior which interfere with normal life. So you can just see the magnitude of what it can do. Sometimes it even brings about questions which are ontological or existential. Existential meaning, why am I here? Why is this happening to me? And ontological is taking one step ahead. Is there a God? If there is a God, why is it happening to me? These are not, these are things which are shared by patients. It's not literature, or it's not verbose things. These are the things which are actually experienced by patients. Now, coming to the classification of orofacial pain, it's very expansive, and it kind of I have to circumvent it because given the scope of my topic and the constraints of time, we all have read about the classifications of pain, axis 1, axis 2, so on and so forth. will be seeing in the course of the presentation, pain, when it becomes chronic, becomes life itself. The patient will suffer decreased quality of life. He may not be able to attend to his usual, work, sleep disturbances. He'll have depression. This adds to the healthcare cost. So pain, chronic pain, is something uh, which I cannot even, sum up the magnitude of. Now let us come and define orofacial pain. Orofacial pain definition is important because this is being given in the year, the current year, 2020, and it goes like this. Orofacial pain is the discipline of dentistry that includes the assessment, diagnosis, treatment of patients with disorders, including TM disorders, neuromuscular pain, orofacial sleep disorders, as well as the pursuit of knowledge of the underlying pathophysiology and mechanism of this. I want to underline, I want to highlight the second part of it is that the pursuit of knowledge of the underlying physiology and mechanism of the pain. This is where we as doctors have a role to play to understand the mechanism of the pain, thereby provide effect. Let's say, how did this speciality came about being a speciality? Life has a history has a strange way of moving like a circle. When the American Academy of Orofacial Pain was established and the first meeting happens with people, we are little too generous for our own good. So it was named as cranium. Then we went to a definition, description called as American Academy of Craniomandibular Disorders. Again, the circle of time turned, and finally people realized it is the American Academy of Orofacial Pain. Let me tell you that I am not a proponent of American Association of Orofacial Pain, but they do have the first movers advantage, and we should give them credit where it is due. Thereafter, uh, thereafter just started opening up. The European Academy of Craniomandibular Disorders, Asian Academy, the Iberolateral Latin American Society. We don't have a orofacial pain society in India, but just like yoga and basmati rice, if it has got accreditation from America, probably we will start it soon. All right. Now, how big is this problem? Is this problem very small or is this problem very big? I like to call it as the unseen deluge. The lifetime prevalence and the need for treatment of orofacial pain disorder is, it compares as much as we are so wired, we are so tuned to being molar doctors that we forget that we extend beyond that, especially oral medicine people. When we have the word medicine itself, we need to address the fact that we can treat these patients and manage them. The prevalence, like I said, it is comparable to any of the dental diseases, be it missing teeth, caries, periodontal disease, not taking away from the seriousness of those. I have statistics again, sorry, it's in American statistics. The percentage of population which is affected by these is as follows, as you can see on the screen, and all that, it amounts to about 20% of pain. It's a huge number numerically, and it can cause a huge burden on the cost of treatment. So let's see what were the founding principles of forming a 12th branch of dentistry. Many would say we already have an overcrowded cap. Why do we need one more branch? So the first founding principle is increase access to care for patients with orofacial pain conditions by improving the knowledge base of orofacial pain. Impart knowledge about pain, impart knowledge about the current scenarios, about what are the developments in terms of pain pathophysiology, and treatment likewise. Now identify doctors, prima facie, it will be oral medicine specialists with knowledge and experience with managing simple to complex orofacial pain problems and provide a resource pool of doctors addressing a specific set of problems. So this was the second founding principle. And we are dentists at the end of the day. So support and expand the role of dentistry in the rapidly evolving field of pain management, broaden the scope of practice, and maintain a very, very high profile in the rapidly evolving field of pain management. Trust me, pain and pain management abroad is probably some of one of the most advanced cutting edge research which is happening as of today. Now, this was the application which I'm sharing with you, which was given out by the American Association of Orofacial Pain to the American Dental Academy or ADA. This is about a 400-page document which they have mentioned the rationale, the reasoning, the workings of um, orofacial pain as a separate branch, and it was thus therefore recognized, justifiably so. There were 6 requirements which were to be fulfilled. Basically, these are to do with American universities. So I would take the liberty of skipping this. Now, let's just see what do we do when we have established a orofacial pain as a separate branch. As usual, or as the norm goes, we assess, we diagnose and treat patients with chronic orofacial pain and dysfunction disorders. Sometimes you may come across patients with oromotor and jaw behavior disorders, which lead to pain again. Chronic head, neck, and facial pain. Again, like I keep emphasizing, pursuit of knowledge of the underlying pathophysiology and mechanisms of these disorders. Some examples, all of you must be familiar of this, all of you must have come across this one time or the other in your practice. Disorders, chronic generalized pain syndrome, burning mouth, pain secondary to orofacial cancer and AIDS, orofacial dyskinesias, dystonias, and sleep disorders. As you can see, you know what makes it interesting about the head and neck area? In your entire body, you don't have such a composite area where vascular, muscular, skeletal, neural, all factors come into play, and any of this can lead to pain, isn't it? So erroneously, we think toothache is what we treat. We do, of course, due respect to that, but the step beyond that is to identify these disorders and to be trained in that. Now, coming to that, the new uh, guidelines are very clear about certain things. I told you what is included in orofacial pain. Now let us see what is not included in orofacial pain. Firstly, much to the dismay of endodontists, acute pain from pulpitis not included, periodontal disease not included, surgical treatment of TM disorders or nerve injuries not included, dentinal hypersensitivity, no, not included. This field also does not include treatment and prevention of acute pain and anxiety from dental, surgical, or operative procedures, right? So at the cost of repeating myself, there's no pulpitis, periodontal disease, TM, surgical treatment of TMG disorders, nerve injuries, and dentinal hypersensitives. Though they are painful conditions, they do not come under the realm of orofacial pain. Now, most of here are oral medicine and radiology experts. Some are being trained. So I want to emphasize the raison d'etre. I mean, the reason why oral medicine specialists have to claim and establish this field as their own. You just don't do it by saying that orofacial pain belongs to oral medicine and radiology. We have to follow it in principle. We have to prepare for it by upgrading our knowledge, and most importantly, bring it into practice. Why us? We are the first checkpoint, right? A gross misdiagnosis, a gross uh, missing of diagnosis, we may just say that it is, pain due to tooth, and we may just refer the patient to another department, and it may not address the patient's needs at all. We are the first checkpoint. Let us all learn the art of conversation, the art of eliciting history from a patient. When you speak to your patient in detail, with a bit of empathy and with a bit of um, authority as well, the patient will give you symptoms which he would not have given you in the first instance. So we are the first checkpoint. We are the one who are going to look at this. So make sure that you do a thorough diagnosis. Secondly, if it is misdiagnosed, what happens? The patient is subjected to a barrage of tests. The patient will run from pillar to post, from a specialist to specialist, not getting any relief. The patient basically becomes a piece in a relay. He just keeps running around, and I don't think we would want that to happen to us. Likewise, I don't want that to happen to any patient either. So prevent helter-skelter diagnosis and care. This is very important. Now, this is actually a word of caution, if I may say so. Infringement. Infringement is something which has uh, troubled oral medicine from a very long point. Forensic odontology, for all practical purposes, was ours, but now we are not anywhere in the picture. So if we don't claim it now, if we don't adapt to it this now, it will be infringed. It will be taken over by somebody. And trust me, to make it interesting, it is quite a financially lucrative practice. It is not just an academic exercise. So please make sure nobody infringes on our territory. With due respect to other departments, we do not infringe on them. And I think what is ours has to be claimed and practiced. Now, what were the pushing factors which made orofacial pain so interesting and a new specialty? Three factors in the recent times, though they have been around for quite some time, but the newer technologies and research, the three factors which spurred this field to come into existence is firstly understanding the neurobiology of pain modulation. Secondly, understanding the concept of chronic versus acute pain. And thirdly, we do not work in isolation. So we may have to use, probably a prosthodontist for, occlusal correction, probably a surgeon for intractable cases of trigeminal neuralgia, basically interdisciplinary teams. But you have to be at the forefront of this field. Neurobiology of pain. We all have learned the transmission of pain. We have learned about ascending pathways, the descending pathways, and how pain functions. And most of the analgesics are designed based on that. Now, what if we could manipulate? What if we could do it at the level of the dorsal horn cell, we could do it at the levels of the neurotransmitter, we could do it in terms of head and neck in the in the area of the trigeminal ganglia. We modulate the pain. Once you modulate the pain, the perception of pain changes, right? So pain modulation is something which is increasingly being used. This includes your medicinal therapy. Now, many of us prescribe tricyclic antidepressants and and anticonvulsants and drugs like this. Technically, are they analgesics? Of course, they are not. But do they have a play a role in, control of pain? Absolutely, yes. So modulation of pain is something we are, it's a field of interest. Now, coming to chronic pain. Now, chronic pain, I just cannot emphasize how big a problem it is. We all have learned that chronic pain is a factor of time. Of course, it is a factor of time, but there are other factors also, which include, you know, lack of right treatment, persistence of pain for years and years, affecting the quality of the patient. Uh, this is probably the most used picture on the internet, the iceberg. It has been used for pretty much everything, but it again delivers the message. It's one of the most underestimated healthcare problems in the world today. Now, chronic pain has been very nicely described by an author called as Fadel Zidin. He says chronic pain is complicated, it's constructed and modulated by a constellation of interactions between the sensory, cognitive, and emotional factors, rendering the treatment of pain difficult and often a financial burden. This has led to what is called as an opioid crisis in America. People are so hooked on to drugs of the opioid class. And on a lighter note, if anybody is a fan of House, you can see how he's been popping Vicodin pills right, left, and center. So chronic pain is something which we have to address because it is going to affect the quality of life. His entire being, starts revolving around the pain. It's a vicious cycle. Pain leads to more amount of stress, of the pain not going, leading to more, uh, more incidents of pain and so on. So this is a vicious cycle, and this cycle has to be broken. Believe it or not, more people live with chronic pain than cancer, heart disease, and diabetes combined. Right? I'm not just talking about orofacial pain, it is the entire chronic pain, be it sciatica or be it any other chronic pain. But basically, chronic pain is of a very, very huge magnitude. If you are interested and if it interests your aesthetics, there is a artist by name Trina Mary who has used the body as a canvas to describe the chronicity of the pain and what it does. It's very illustrative and it is also very disturbing. You can Google and have a look. The artist name is Trina Mary. These are some of her illustrations which are showing that the person is basically bound or shackled by chronic pain. Like I said, chronic pain starts with tissue damage, then it leads to emotion, suffering, and behaviors associated with pain, which will have a role with the outside environment. Like 135 for us. Yeah. So sorry about the glitch, but those who are following the series Dark, I would like to say everything is connected. All of these are connected. They're no individual entities. They are all connected to each other. Now, let me talk about diseases and certain diseases because, like I said, there is paucity of time and I don't want to extend it beyond, uh, the allotted time. We will talk about what is the current management of trigeminal neuralgias with neuralgias with trigeminal neuralgia as a prototype. Very familiar definition for us: unilateral pain, brief electric shock like pains, unilateral, limited to the distributions of one or two divisions of the trigeminal nerve. There is a revised classification by the ICHD which tells us what is classic or essential or idiopathic pain and what is secondary trigeminal neuralgia. So, what are the developing treatment options? I'm skipping the ones we are all familiar with. You have prescribed carbamazepine, I have prescribed carbamazepine. At this point, I want to tell a small anecdote, if I may. We all have read about trigeminal neuralgia. We know we keep writing, that the patient is not going to shave, is not going to wash his face. The very first time I saw a patient of trigeminal neuralgia on a dental chair, I was flummoxed. I was, I was lost because there is a patient sitting on the chair who was all right a few minutes back, and now he is wincing with pain, and the kind of emotion which the patient generated was something, it has to be seen to be believed. That's the reason why people even call it as a suicide disease. Well, let's not get too negative about it. So, what is the developing treatment options? There is a novel substance which technically is a sodium channel blocker. It has an acronym BIB074. The trade name for this is Vixotrigine, formerly called as Raxatrigine. It's a new drug which is showing high amount of promise in the treatment of trigeminal and other neuralgias. This drug was able to reduce the symptoms of trigeminal neuralgia by 50%.
Sorry, there seemed to be a technical glitch.
Yeah. No,
Yeah,
it's a weekend. Probably even the internet needs a break.
yeah.
All right. So let's
Yes,
come
doctor.
to the next part, that is the neuromodulation techniques. That is modulating the way the pain is perceived and the pain happens. There is a latest or a new technology which is called as repetitive cranial transmagnetic stimulation, the acronym standing RCTMS. In the coming years, for those who are students, this may become a common, parlance and practice. What does it do? It's a rapidly changing magnetic field which passes through a scalp and skull and generates small electrical pulses in your brain. It causes the neurons to fire and increases the circulation of blood in your brain. If you have read this slide carefully, it exactly follows the gate control theory of Melzack. So this is a new modality which may be in practice quite soon. Now, temporomandibular disorders are the second set of disorders which I'm going to talk about. Temporomandibular joint is a composite. It has bones, it has cartilage, it has so yeah, I was at this. Now the fundamental of TMDs, ask any doctor across, is to reduce chronic and long-term drug usage. It does offer relief, but over a period of time, it can lead to substance abuse. So, what are the three newer modalities which are there for the treatment of temporomandibular disorders? The first one is called as biofeedback assisted relaxation technique, or BART in short, with no relation to Bart Simpson at all. Second is surface electromyographic training of masticatory muscles. And thirdly, and probably importantly, is cognitive behavior therapy. In BART, what we do is, what is done is, we harness the body's own system to get a positive feedback and change the perception of pain, and it is giving excellent results. The SEMG is again a counter stimulation of the masticatory muscles. Again, control theory comes into play and it gives immediate relief to the patient. Cognitive behavior therapy is probably the realm of psychologists, but then again, we are also equipped to handle, the basics of understandings of the mind. Thoughts create feelings, feelings create behavior, behavior reinforces thought. So if you break it at any one level, probably you will have a good result. These two are not very new: iontophoresis and TENS, that is transcutaneous electric nerve stimulation. Again, they give good results in cases of temporomandibular disorders. Something which is gaining traction, something which is gaining interest, is about neuromuscular dentistry. Everything in life is about balance, it's about harmony. So, neuromuscular dentistry, uh, we are privileged to have Dr. Tatu Joy, who is a pioneer in this. Probably will shed more light on this than me. It's basically the interplay of these and maintaining a harmonious relationship. Neuromuscular dentistry looks at the joints, the muscles, the nerves, and the teeth, the whole system that makes your bite or your jaw position to happen. Misalignments in the system can result in a variety of chronic conditions, surprisingly, headaches, facial pain and jaw pain, even sleep apnea, and depression. Neuromuscular dentistry, like I said, restores harmony to this system of jaw joints, muscles, teeth, and all. This may involve multiple techniques. The, the doctor, as per his judgment, can use a TENS device, can use orthotic plastic mouthpieces, sometimes even orthodontic treatment to adjust the bite. Sometimes you may require significant restorative
Hello everyone. Sorry, looks like we've encountered some technical glitch. We're trying to rectify that. Please bear with us. Thank you. Yes, Doctor.
Yeah, right.
Okay.
Yeah,
Prof. Yes,
yeah,
Prof. We can hear you now.
yeah, right. I'm sorry for this technical glitches. This is beyond.
Prof. Can you hear us? We're sorry. Actually, we're encountering a poor connection. We are trying to rectify the issue. Please, audience, we request you all to kindly bear with us for 2 minutes. Prof. Prof. Vaseem, can you hear us? Sorry, everyone. We're trying to reconnect to Professor Vaseem. Meanwhile, if you have any questions regarding the topic, you can type it in the Facebook comment section. We can bring it up during the panel discussion. Thank you. Yes, Prof?
Yeah.
Yeah. Now,
I'm back. Yeah.
welcome back, Prof. Yeah.
Thank you. Yeah. Yeah. Lastly, I will be talking about atypical
Prof. Vaseem, can you hear me?
Yeah.
Yeah.
Yes, ma'am. Yes, ma'am.
Prof, maybe we can switch off your, try switching off your video and see if,
No, I think I'm almost done. So
okay,
we-
okay.
yeah.
Thank you. You
So
can go ahead.
what's the road ahead for us? The road ahead for us is, as oral medicine practitioners, we need to incorporate this, and also for the upcoming graduates, there are a lot of avenues for you to take it as a profession by itself. It has a huge, potential which has to be tapped. Now comes the question, do we overhaul our entire practice? This is a very scary scenario for a dentist. No, we did not have to overhaul our entire dental practice. You may begin with as simple as a diagnostic nerve block, which doesn't require any special armamentarium. And what is called as escalation of practice. You learn new skills, you acquire new equipment, and that's how you build your practice towards oral medicine. I mean, orofacial pain. So the takeaway message is that orofacial pain justifiably has been accorded the status of the 12th branch of dentistry. It is time for us to look at this in depth, make sure that, for the general dentist, we also have to give a word of caution that do not overstep your limits. And when required, please refer it to a consultant. So this is the conclusion. And early Saturday morning, I hope I didn't make you yawn, because yawning also causes orofacial pain in the long term. Well, I would like to thank, especially the team from Ames University, Dr. Priya specifically, followed by Dr. Ramesh, Dr. Ravi, Dr. Neeraja, and Miss Vilasini. And do stay safe, take care of yourself in these testing times. Those who need to contact me can contact me through the Amropin webpage, or these are my details. And I'm up for the panel discussion. Thank you all for a patient hearing and bearing with the technical glitches. Thank you so much.
Thank you so much, Prof, for sharing your experiences on the current topic. And we also apologize for the technical glitch that has encountered, as we've already mentioned that all the speakers and all of us are logging in from different countries and different time zones. So yeah, thank you so much. And
Unanticipated things, yes.
yes, unanticipated, yeah. So now I would invite my co-host, Dr. Ravi, to moderate the panel discussion session. Thank you.
Right. Thank you. Morning, Dr. V.
Good morning, Prof.
Morning, Doctor.
Yeah, good morning to all the panelists.
Sorry, Dr. Ravi, very sorry. Dr. Wasim, I think Dr. Wasim need to stop the screen share.
Oh, okay.
Okay. Yes.
Sorry,
Thank
and
you.
thank you very much.
Thank you.
Yeah,
Thank you,
thank
Ms.
you.
Valasana. I request, before start with the panel discussion, I request all the panelists to switch on their videos and unmute themselves for the discussion, please. And today, we have three panel experts for this webinar session. Our first panelist is Professor Dr.Tatu Joy, equipped with a master's degree in oral medicine and radiology. Dr. Tatu Joy has over 21 years of experience in his chosen field. He is the director and consultant at Maxillofacial Diagnostics, a head and neck diagnostic center at Kochi, India, which is the first center to exclusively practice OMR in the country. Furthermore, he is also a managing director at Dr. Tatu's TMJ Head and Neck Pain Care, the first neuromuscular TMJ center in the country. Currently, Dr. Tatu Joy is a professor, head of department at Sri Mukambika Institute of Dental Sciences, India, and a PhD guide at Pacific University in Rajasthan. Welcome, Prof. And the second panelist for the day. The second panelist for the day is Dr. Sajjad Salam. He is an undergraduate alumnus from the Manipal College of Dental Sciences in the year 2000, with an MDS in the field of oral and maxillofacial surgery from Bangalore Institute of Dental Sciences. Dr. SAJJAD pursued his post-graduation with zest and was privy to surgical challenging cases, following which he now works with the Ministry of Defense in Bahrain. Welcome, Dr. SAJJAD.
Thanks. Thank you.
Okay. And for the third panelist for the session, I'd like to introduce Dr. YESODA A. Currently, Dr. YESODA is a senior teaching faculty at the acclaimed SRM Dental College and Hospital in Chennai. She's an accomplished postgraduate with masters in oral medicine and oral radiology from JSS Dental College and Hospital, Mysore, and is well versed in the diagnosis and adept management of lesions, as well as disorders of oral cavity and jaw. Dr. YESODA is an avid academic and has mentored numerous postgraduate students for the national research presentations. And she herself has attended various conferences, seminars, and workshops. And she also has to her credit multiple national and international publications. Welcome, Dr. YESODA.
Thank you, sir.
Thank you, Prof. Vaseemuddin. We would like to go ahead and take some questions from the audience. Just a reminder to the audience, please be sure to type your questions in the Facebook comment section. And I guess we have a few questions. One of the, it looks like we have one question here, which says, which classification is widely accepted? So any one of the panelists can, even the speaker can address this.
I would suggest Dr. Sir to start the conversation.
So I request all the panelists to unmute themselves. Yeah.
About classifications and all that, I think Dr. Wasim has already spoken about your axis 1, 2, and 3. I go by those classifications. And personally, I am not somebody who is very fanciful about classifications or definitions. I like to see results with my patients. So I would like some of the other panelists who are, really into the academic side to take it forward.
the Doke's classification still holds the prime value as
Okay, and there's another question from one of the audience. When do we do surgical intervention for trigeminal neuralgia cases?
Well, like I said, pharmacotherapy is the mainstay.
I think I think Dr. Wasim is having some problem with this
Yes.
video
Yeah.
and is online. So I will take,
Yes, please.
if
Thank you.
all the others are okay, I will take over. Now, I have had actually very good success with around 9 to 10 trigeminal neuralgia cases. These were not diagnosed by me as trigeminal neuralgia. They were diagnosed by the neurologist as trigeminal neuralgia. They were put on medication. Okay. Now I realize that probably what we see, we say that it could be a neurovascular compression in one of the cranial nerve roots, and we could some growth, some accident, trauma that could have initiated the neuralgia. Okay, now keeping all that apart, if you are actually in an MRI, you are able to see a compression, or if you are able to see a nerve conduction study where there is a problem, then absolutely what they say is right. But till then, I believe that all these nerves travel between muscles, and any muscular compression can also create the same undesirous effect. So I feel once you relieve the muscle or the muscular dysfunction, we are getting the patients back into normal. And this is, I'm talking out of experience, as I told you, around 8 or 9 cases. Now, when do you need surgery? I'm not saying that you don't need surgery. Now, just recently, a week back, I had a patient who is allergic to all medication. You name it, whatever we use for head and neck, rather trigeminal neuralgia, she's allergic to. And that means you can, unless we get the pain into control, we cannot start any muscular protocols or any jaw positioning protocols. So unless you get the patient out of pain, it is difficult to get there to this thing. So that patient is actually undergoing surgery today. No, she would have had it yesterday. They say they are going to do microvascular decompression. But frankly, I don't know. There has been a couple of MRIs done. And frankly, I asked the neuroradiologist, where do you see this compression? If you're going to do decompression, then there has to be some compression there. Where do you see they have no clue. So I frankly don't know. But anyway, I understand that it is beyond my means of correcting it, unless because she's allergic to everything, anything and everything. So she has undergone surgery yesterday. I can keep you posted once she comes back with the results.
Okay. Thank you.
I would like to add upon something.
Yes. Yes, please.
Trigeminal neuralgia, basically microvascular decompression, as per evidence, if you go, it is an effective treatment. There are lots of treatments. I didn't hear anyone talking about, as Dr. Tatu mentioned, he mentioned about neuromuscular modulation regarding, modulating the muscles for a trigeminal pain. I don't agree to it because it's very difficult to manage these patients. So when do you go for surgery is when you are done with the medical management. When, there is a point where you reach where you can't start, you can't keep giving patients, try your combinations of lamotrigine or carbamazepine or oxcarbamazine. So when you reach a point, no, there's a limit to it. You refer the patient to a specialist neurosurgeon. And, if there is a secondary trigeminal neuralgia, yeah, he would be able to treat it. If it is a classical trigeminal neuralgia, you go with neuromodulation techniques. I think that should be it.
Thank you, Dr. Sajjad. Prof. Vaseem, would you like to add any note on this? Because you wanted to
Yeah, yes, sir. I mean,
Please. Thank
though
you.
medical treatment is the mainstay, when you have reached the maximum dosage of a certain drug like carbamazepine, for example, it does have effects on the bone marrow, suppression and dyscrasias. So there is a line where we draw that we cannot medically treat it. It becomes intractable. Then, of course, surgical treatment is, comes into play, and definitely, um, it's a surgeon's call as to what best treatment can be done. So intractable pain or becoming resistant rather to the drugs is what.
Okay, Prof. Thank you. And there's another question from one of the audience. Uh, I presume Dr. Yeshoda may answer this. How do you differentiate between oral pain, orofacial pain with odontogenic pain clinically?
Okay. One of the things, and this was told to me by my professor, and I think it's the most simplest thing, and hence I remember it for the longest time. So, orofacial pain and odontogenic pain, whenever you are coming
And
across
there's
this
another
case,
question. Uh,
yes,
yes, please.
sorry.
Continue. Yeah.
Whenever you are coming across this case in your clinic or whatever, first and foremost, always check the oral cavity, rule out the most commonest things possible for the pain. In the absence of any oral cause or odontogenic cause, mostly in the absence of any odontogenic cause, then is when you're supposed to look for the orofacial causes. Other than that, of course, when they tell you the symptoms, the most as you grow with experience, it will just come to you with your acumen. When they describe the symptoms itself, that they are bending more towards the orofacial pain than the odontogenic pain.
Okay.
That is what I remember.
Thank you. Thank you, Dr. Yeshoda. There's one more question. Uh,
Yes.
What is the most suitable medication which you would prescribe for pregnant patients with neuralgias?
Uh, so here, as such, we are still giving them. We try to control it with carbamazepine itself, even when though actually speaking, never actually come across neuralgic pain in that particular age group yet. Uh, we are still continuing treatment, the initial treatment with carbamazepine itself.
Okay. Thank you, doctor. And Dr. Sajjad, there's one question. One of the audience asks, what emergency medication can we prescribe for patients with severe pain? Because some of these medications tend to have a
As
potential harmful
acute
effect on
pain.
the liver or the.
Acute pain, a patient comes to you in front of you, easy, if he's in acute pain, just give him a good nerve block. And that actually, relieves his pain, his fury, everything. You just give him a good nerve block. That's the best thing that you can do in acute pain.
So, what about the medications? Because some of these medications that we prescribe to the patients tend to have a harmful effect on the, liver or the kidneys. And like Professor Waseem has explained earlier, chronic pain seems to be the major cause of cause of pain among most of the people worldwide, more than diabetes and hypertension and other disorders together. So when we prescribe medications for chronic pain, it tends to be long term, and when it's long time, it will definitely have a detrimental effect on the liver or the kidneys. So what would you suggest would be the best medication when you're prescribing for a long term?
Where neuromodulation comes into play. Physical therapy, therapies like biofeedback, which offer an alternative to prescription medication. Because prescription medication in an Indian scenario, though we do not prescribe opioid can lead to a crisis. It can lead to, not just the harmful effect, the patient will end up being a junkie. We don't want that to happen. So neuromodulation or modulating the way the pain is perceived is probably one of the things which we should be looking at now, because pain has a comprehensive phenomenon. It is not just the fact that there is an injury, it is also got psychological bearings, it is also got the the social circumstances, all this is included. We prefer neuromodulation, you know,
Uh,
pieces
I,
which are suitable for that. Yes, yes,
Yes,
yes,
Dr. Sajjad. Yes, please.
yes, Sajjad.
Thanks for that.
like Dr. Wasim mentioned, neuromodulation is a good idea, but in a resource constrained country like India, it is difficult because of the cost
Yes,
involved. That's one thing.
yes,
Secondly, now I would disagree with him giving opioids long. I mean, you can put on. There are lots of patients of mine who are on opioids, like for about 2 months, 3 months, on a short dose of opioids. We keep them on either codeine or Percocet. They continue with it because of this chronic pain, and pain is subjective, so it's either it's me or you. We will not be able to we will not be able to make out what the patient feels. So you have to control the patient's pain. Every day morning I come across a patient, because I have a separate pain clinic, wherein we have a psychologist, we have a psychiatrist, we have a dietitian, and restorative dentist at hand, and we have a pain specialist as well, who basically goes with nerve blocks, using fluoroscopic methods and things like that. So we are a bit more aggressive in managing pain. Probably in this part of the world, people are more sensitive to pain.
Mhm.
So chronic pain. Now, if you talk about TM joint pain, over the past 6 to 7 years, we have been advocating Botox, and this thing has been working wonders to TM joint pain patients.
but Sajjad, I would like to differ here. When you prescribe a drug, you are under controlled circumstances. Understand? Let us say that you have prescribed the drug for an X period of time. You have prescribed. How do you make sure that the patient will not have a drug seeking behavior? How do you stop that? How do you stop abuse?
See, we don't go overboard, because see, I work for the public health system here. So
Yes.
if I prescribe a particular medicine for a patient, if I say the patient needs it to be taking for
Yes.
1 month, the
Yes.
drugstore dispenses it only for 2 weeks. So
Okay.
the next visit, you assess the patient again. If you
Yes.
still feel, then you have to continue with the drug. And it's a low dose. It's not, we don't go with high doses.
No, no, let us say in a country like India where it is unregulated to a large extent, over the counter probably you can buy pretty much anything, to pesticide to God knows what. So how does one regulate? How does one prevent one from becoming, uh,
See,
addicted to that drug? Of course
see,
it
I,
does, I mean,
I have practiced in India for quite a while,
I
and
know, yes,
the practice of prescribing opioids, I developed it after coming here, because it's this because probably this part of the world, I told you, people are more sensitive to pain. It's not only opioids that we prescribe. We start off with TCAs, and this opioid is not for every patient. This goes with on a patient to patient basis. So I have come across patients abusing it, but that is you say, take 10 patients, I mean, take about 50 patients, one or two, yeah, you have seen them abusing it. But we don't, we basically, what I look at it is, how the drug is going to elevate the patient's discomfort of pain. Pain is very subjective, and it's, you can't explain it. How if one of us gets a small toothache or a small back pain, we keep roaming here and there. It disturbs our sleep, normal activities. So that's how it goes for me, basically.
Thank you. Thank you, Dr. Sajjad. And there's one more question. I would like to add this question to Dr. Tatu Joy. It says, can you throw some light on the headaches and migraine management and the role of a OMR professional in these conditions, please?
Wow, I love that question, to be frank.
Thank you.
That is why I'm here. Whoever asked this is like, what the physician wanted and what the patient wanted. It's something like that. Okay. Right. Okay. Now, I'll start with my experience. As I told you, I don't want to take more time, so I'll be quick with it. So around 21 years, I've been doing diagnostic work, what we are taught in with the oral medicine and radiology classes. So I started a specialized center. So we've been doing diagnosis, and we've been realizing that most of these pains, as we earlier discussed, the classification and treatment plans, what were done by our seniors. Definitely, we stand on their feet. Okay, we see the world on their shoulders. Appreciate whatever they have done, like Okeson, Bell, and all. Okay, so we did diagnose it, and then some of these patients came back saying that I'm not getting the right treatment because I was running an exclusive diagnostic center. I never did treatment there because the idea was, for people to confidently refer to me for all these diagnoses. And if I treat, then they will not be able to do that confidently. You understand the mathematics. So this was happening, but then so many patients came back to me saying that when you palpated or when you touched those areas, I knew that you knew what you were searching for. But unfortunately, those who are so-called specialists in the field never got me out of the pain. It's medication after medication after medication, different kinds of medication. So then,
Polypharmacy, like Mrs.
actually, what put me, I'm some, for me, oral medicine radiology in itself was too much to study. So I'm not a fan to go around studying neuromuscular dentistry or biopsychosocial or all the other TMJ and head and neck pain facilities that are available all the world. But these three patients pushed me into doing that because they said, if you don't find something for this, we are, as you said, the psychological aspect is also very important. They were finding it very deep and they were considering suicides. So when it came to that kind of a situation, I was forced to learn. Okay. So then I went around the world looking at what are the different options. I have no complaints to whatever options that people take. But there are a lot of things that I have realized. I follow something called neuromuscular dentistry. I reached there last, in fact. So I've gone through the other specializations. Now, neuromuscular dentistry is basically about the neuromuscular balance. Okay. Now, it's a very simple thing. When you, this is for the oral medicine radiologist here. I may be a bit boring. Dr.SAJJAD is already yawning, but I have to do this. So I'm sorry. Okay. Now, I understand. No problem. No issue. Okay. So then the problem is we see the mouth as just the teeth and, bite, occlusion. That's all that we see about it. But have you thought about it? This jaw joint is the highest joint in the body. There's no joint beyond that. Have you thought about it that this joint takes maximum load when in a fight or flee situation? Okay, that means around 500 to 700 Newton force is taken by this joint, while the entire spine takes 2,400 Newtons, but you know the number of bones there. This is one bone, only the mandible moves. So this is one bone taking that much of load, okay? And the possibility of a bite related issue is much higher than somebody having an accident or somebody having a back problem because of any other trauma or things like that, because this human machinery is quite well equipped and very strong. If you're looking at this the skeletomuscular system, it's quite strong. So you can have a descending problem that starts from here, which goes down, okay, ripples down, or you can have an ascending problem from the big toe up. The probability of having things more is with dentistry. Because I feel the number of people having toe surgeries or knee surgeries or ankle surgeries is much lesser than people having dental care. Would you agree that much?
Absolutely.
Very much.
So either we are iatrogenic, okay, either we are iatrogenic, but we have already started causing something that is that important. And this joint is the maximum used in the body also.
And sir,
I will provide data for all
probably
this, whatever I'm talking about. It's the maximum use joint, maximum force joint, and it is hung here. It is just hanging around here. So it's like a hanging bridge design. Now, a hanging bridge design, it does, with this much of force cannot be just, there's no support pillars. It has to be the ropes, and the ropes are the muscles. So the
sir,
muscles
and
are the ones. Yeah,
correct me if
please.
I'm wrong. This is the only composite joint in the entire body, where bifunctionally, I mean, functionally, it's two joints functioning as one. I don't think there's any other. We have elbows, we have knees. So this again
Yeah,
makes it, by
they
virtue of
call it the husband and wife joint. Like if both are in nice synchronicity, the patient has no problem. The moment one is fighting with the other, you have a problem. It's
correct
easier to
analogy, sir.
remember. It's one of my
Marriage
teachers
is
who taught me that.
balanced and harmonious.
Yeah, harmonious relationship, then it's fine. So this is the concept that is there. Okay, and wherever I've got an opportunity to speak, I say this because all of the oral medicine people, we are all sitting on a big, gold mine, and we don't realize that. Okay, just pull yourself out of this, all these classifications and all these. Just think practically, think logically. What am I saying? Is this logical? It's very logical. In the sense, frankly, you're having an accident where your back is crushed, or you're having a dental treatment, which is more simple. So the
Oh,
moment this balance goes off, it will ripple down to your body. That is my this thing, and that is probably why, Dr. Sajjad, as you said earlier, I have very good success in the sense I'm talking about trigeminal neuralgia, around 9 cases. All those are documented. The things are there. I'm in the clinic actually. I can post it if you want. Uh, from no medication. Okay, they are totally no medication, just neuromuscular reconstruction, because they have lost teeth and floating that migrated. So those are all corrected. Now, wouldn't you think that would be the best option overall the other options that we are just talking about?
Dr. Tatu,
Yeah.
see, I won't say that, trigeminal neuralgia is a diagnosis of exclusion. A patient goes around correcting his teeth, correcting his gums, again and again, he comes with, the same same complaint of paroxysms and, shock-like pain.
Trigger points and all.
Yeah. Then you end up with, something. Then you start doing, to rule out any secondary causes for this trigeminal pain. Otherwise, you end up with something called as classical trigeminal neuralgia. Now, once you get classical trigeminal neuralgia, obviously, all of us, we start the patient on Tegretol. You start with a small dose of 200 or 300 mg. You gradually keep on increasing it, and again, Tegretol is diagnostic of trigeminal neuralgia. In the meantime, you buy time, do the required basic investigations. You do a blood workup and things like that. Do the radiological investigations, get an MRI scan using, probably, gadolinium enhanced scans and things like that. Rule out your basic causes. If the patient is responding, continue with this particular thing. So again, neuromuscular dentistry, frankly speaking, I don't have much experience in it. So I wouldn't be commenting on it, but correcting, the joints and musculature, if it helps, it helps. It's good for the patients.
Can
That's
I
all I
digress
have
a bit?
to
A
say.
little.
okay.
I want to digress a little bit, and I think among the infinite technical glitches, I forgot to mention that Dr. Sajjad and me were batchmates, and we have been best friends from 1.5 decade now.
Oh,
So
lovely.
I had vested
That's nice to
interest in getting
hear.
him.
And there's one, I'm sorry to
Yeah.
break in, but there's one question from one of the audience. What are the new drugs that are being prescribed for trigeminal neuralgia?
Just like
Anyone
I
can?
told you, sir, there is a sodium channel blocker, which the name I just mentioned. and of course botulinum toxin.
Okay, sir. And one last final before we end up. What's the difference between a burning mouth syndrome and a burning mouth symptom? That's a specific question that was directed.
Pardon me?
Burning mouth syndrome. Anyone? Dr. YESODA can answer.
So actually, I didn't get the question. What is the difference between?
What is the difference between a burning mouth syndrome and a burning mouth symptom?
From a burning mouth syndrome, Hello?
Yes, madam. Yes, ma'am. Yes, ma'am. Please continue.
Actually, I'm getting cut off in between. I'm thinking they're asking about burning mouth syndrome, in which case, obviously, you would diagnose it based on, first of all, the patient complaining about a burning sensation in the entire oral cavity, especially most commonly age-related, older individuals, females going through menopause or hormonal changes, and which would not be elevated by any usual medications, and it is not stimulated by any cause either. Okay, this is what I understood, and obviously your textbook treatment with clonazepam is what I'm understanding, and a burning mouth symptom, my understanding of it is that it would be associated with a primary cause. It could be from any nutritional deficiencies or any other conditions like that. This is my best understanding of it, sir. If any of the other panelists would like to add to it, with.
May I add to it a little bit? There are burning mouth syndrome. There are a lot of cases there were a lot of cases with me, and even a case of palatine myoclonus. Now, as you said, clonazepam, all those medication, we kept doing it, but for how long? And then one day, some brainwave hit me like, why not try neuromuscular? Most of these patients have dental issues. So I brought some of them. Absolutely, these are trials, so we don't charge them. I put them on our ultra low frequency TENS. Okay, and you won't believe they slept through the program, because these people were burning mouth. To the question that was asked, a burning mouth syndrome is where you have 24 hours a burning mouth. The entire oral cavity is burning. And for a burning mouth symptom, that means it could be something, you had something too hot and you have a burn or something that stays for a few days, which heals off. Okay. Now, these are patients I'm talking about, 3 years of no sleep, just burning all the time. Okay. And once that TENS worked on her, because when we do the TENS, we use cranial nerve 5, 7, and 11, and we get the muscles relaxed. Okay, the moment that relaxed, she slept off. She was snoring. In fact, the videos are there. And then we gave her an appliance, and you won't believe, she is absolutely, not only she, I have 3 cases here in Kochi and one in the college where my colleagues have also done the same thing. And 4 cases, no medication, they're just wearing an appliance. But the problem with, unlike trigeminal neuralgia patients, where they're ready to go in for second phase, getting the teeth and all that corrected, burning mouth syndrome, people think that we have luckily got there somehow. It's not because of our merit. So they don't want to do anything other than keep the appliance and go around. They are pain-free, they're very happy, and that's all they want to do. So I cannot go forward documenting all these, unless they finish off the entire thing.
Okay.
So that is what I wanted to add to the discussion.
Thank you, Prof. We've already, this is the end of the session, and it looks like we have covered all the sessions for this webinar. Thank you very much. And a gentle reminder for tomorrow's talk, it's on oral cancer by Dr. Mohit Gupta. And please join us same time tomorrow. And thank you, everyone. We really appreciate you being here. And we'll see you next time. Thank you. Thank you, everyone. Dr. YESODA,
thank you for hosting us.
Sir.
Thank you. Thank you.
For hosting
Thank you,
us.
sir.
And
Thank you,
to
Dr.
Amropin,
SAJJAD.
to Amropan especially for having started out something that's very beautiful. You know, Corona times are difficult. You know, these kind of mind stimulants are always good. Okay, and all the best to all the other panelists, Dr. Yesoda, Dr. SAJJAD,
Thank you, sir.
and
Thank
Dr.
you.
I
Vaseem.
think Dr. Tatu and me go a way long back actually. I don't think so. He should be remembering me. I used to be associated with dental colleges in and around Cochin actually.
Oh, okay. That's why your
We have
name was
spoken a
familiar.
couple of times.
Okay.
So
Okay.
anyways, it was nice seeing you.
Thank you. Thank you.
I went bald just a couple of 1 week back, but it's all growing back. In your
No,
case,
I
don't
shaved
think
last
it's happening.
night actually.
Okay, that's nice. A pleasure meeting you
Thank
guys.
you. Thank you. Thank
Had
you
fun.
all.
Yeah,
Thanks
thank
for
you.
joining.
Yeah,
Thanks.
bye.
So,
Bye
see you
bye.
until we see you next time. Thank
Bye.
you.
Yeah,
Yeah,
bye.
bye.
Bye.